is Marinel Olivares. I'd like to thank you for the invitation to be here today. I am grateful for this opportunity to be able to share and talk about an important topic surrounding patient and family goals of care. As a brief background, I am a licensed clinical social worker at City of Hope. I am also a program specialist for the Patient and Family Goals of Care program with the Department of Supportive Care Medicine. I have been in the field of psycho-oncology for the last 12 years. That's actually about the length of time that I've been working here at City of Hope. I started working here about 12 years ago, and I primarily work with hematology and bone marrow transplant patients. Before we get started, I'd like to share with you about what today's discussion is going to look like. We will begin with a case vignette, and then we'll talk about why patient and family goals of care meetings matter. We're also going to define what a patient and family goals of care meeting is. And by the way, throughout this discussion, you will probably hear me refer to goals of care as GOC. Obviously, that's a shortcut or an abbreviated version of goals of care. We'll also talk about the optimal time for goals of care meetings to occur. And then lastly, we will explore and discuss more about goals of care meeting preparation, including goals of care meeting structure. So this case that I'd like to share actually happened a few months ago here at City of Hope. I have changed the name of the patient in order to protect his privacy. So let's call this patient Mike. He was a 21-year-old male with relapsed and refractory lymphoma. He came to City of Hope for treatment and received multiple lines of therapy, including a clinical trial. However, his disease was very aggressive, and unfortunately, he did not respond to the multiple lines of treatment. As his disease progressed, he was transferred to the ICU for respiratory failure and was placed on a mechanical ventilator. His condition was further complicated with infections and kidney failure, requiring him to be on dialysis. So as Mike continued to stay in the ICU, his condition also continued to decline, and it was evident that he was not going to survive his disease. With his very poor prognosis and low chances of a meaningful recovery, multiple family meetings occurred to discuss about the goals of care and decisions for him. Medical recommendations were made to change his code status to do not resuscitate, meaning that if his heart stopped, CPR will not be performed given his poor prognosis and unlikelihood of a meaningful recovery. And medical recommendation was also made to transition his care to comfort. Mike's mother was his primary medical decision maker and had a really difficult time coming to terms with Mike's condition and medical reality. She wanted aggressive medical care to continue for the patient, despite the care being futile. The case was eventually escalated to the bioethics committee. Patient's mother reluctantly agreed with the medical recommendations, but also expressed a lot of anger and a sense of abandonment. So in thinking about this case, frankly speaking, this was quite a complex and an emotionally difficult one to think about. Clearly, there was a lack of alignment and significant disconnect between the medical team and the family's decisions with regards to goals of care for this patient. It was also a very delicate balance because we wanted to make sure that the family felt supported, that the family felt that their wishes were being respected and that they were being heard, but at the same time balancing that with also what's medically reasonable and ethical for the patient. And I think this is a common challenge and situation that we come across, here in the country, the United States. Here we have a culture that highly values patient autonomy, patients' right to self-determination, but sometimes this can also come into conflict with what's ethically and medically appropriate for patients. And this is why we want to talk about goals of care, because they matter and they're important. And life-threatening illness is hard. When I think about the case vignette and I think about the patient's mom, I could just imagine how difficult it must have been for her to know that her son was dying and to make the hard decisions that she had to make, as reluctant and difficult as it was for her. At the same time, it's also important for the medical team to make sure that we are able to provide honest and accurate information about the patient's condition. And of course, doing it in a compassionate manner, because the last thing that we want to portray and give is false hope to this family. Critical medical decisions are often made without patients and families fully understanding the medical facts and without the medical team fully appreciating a patient's goals and values. In fact, research shows that 60% of patients want to die at home, but only 40% of them do. 77% of elderly patients want palliation or relief of their symptoms at end of life, even if that means living for a shorter amount of time. This disconnect of information often results in more aggressive medical care at end of life. Statistics show that 47% of stage 4 colorectal and lung cancer patients get aggressive care at end of life, and 12% of cancer patients receive chemotherapy in the last 14 days of their lives, which we know does not have any additional survival benefit and is oftentimes associated with increased rates of ventilation and death in the ICU. And as what the Journal of American Medical Association says, this aggressive medical care at end of life is associated with worse quality of life for patients and worse bereavement for families. The patient and family goals of care meetings can address this disconnect. It has been shown to lead to wishes, increased amount of patients' wishes being known and followed. And it can also lead to less aggressive medical care and increase in earlier hospice referrals. Now, with hospice, in case you're not familiar with the concept of hospice, it is a philosophy in which the focus is on the comfort and quality of life of the patient. The intent of hospice is not to cure the disease, but to aggressively manage a patient's symptoms and make sure that the patient is free from pain and is as comfortable as possible. Hospice also provides multidisciplinary support, meaning that they have different members of the team supporting the patient and their families. And this team can include physicians, nurses, clinical social workers, chaplains, and child life specialists. And by the way, child life specialists provide age-appropriate education for children or grandchildren of our adult patients. So we've talked about the importance of patient and family goals of care meetings, but what is really a goals of care meeting? What is its definition? Essentially, it is communication between the medical team, the patient, and the family. It's an opportunity to reconcile medical recommendations with patient values. A patient and family goals of care meeting should also include an assessment of patient and family's understandings, values, and goals. And this is an important piece, part of the meeting, because before we start going into the discussion of clinical information, we want to get a sense of the patient's and family's understanding of where they're at with the disease. From there, we will know if there's any disconnect, if their perception is actually aligned with the patient's actual clinical status. And if there's a gap, if there's a disconnect, then that's an indication and a trigger for us to make sure that we are able to reconcile and correct that misperception. It's also an opportunity to share information and provide education about their diagnosis, treatment, and prognosis, of course. And not only that, we want to make sure that there are concrete or next steps or clear treatment plans so that the patient and families would know what to expect. And in some of my experience in having these goals of care conversations, sometimes they can also be emotionally charged, which is not uncommon. In situations like that, it is important to make sure that we provide emotional support, psychosocial support to patients, and able to address their distress, because it's also one way that we help them and we build trust and we build relationships with them. So when should a goals of care meeting occur? Historically, it has been occurring when there's a crisis situation, and that's something that we want to avoid or prevent, because it's a lot more difficult for patients or families to carefully consider and think about their decisions when they are already in the middle of a crisis situation. So we want to consider a more proactive approach. We want to orient them early to the idea of family meetings. When someone is diagnosed with a serious illness or a life-threatening condition, we want to make sure that we're able to provide that opportunity so that we can provide education, help them better understand about their clinical status. Also, when patients have failed multiple lines of therapy. And ideally, we want this to happen in the ambulatory setting before there's even more medical crisis that would result in a patient's admission to the hospital. So, in short, clinicians have a responsibility to offer family meetings as the situation demands. Here at City of Hope, we actually have a patient and family meeting program in the ICU. We instituted goals of care meetings as part of ICU standard of care because we know that when patients are admitted to the ICU, it can be a source of significant distress for patients and families, especially when they have a lot of questions and when they don't know the next steps in their treatment plan. And by providing that clear communication, timely communication, and timely support, that's also one of the ways that we can enhance the patient experience and make sure that we provide excellent care. So we've talked about the importance of goals of care meetings. We've talked about when they should happen. We've defined what a goals of care meeting is. Now let's explore a little bit more on how to prepare for a meeting. It sounds pretty simplistic, but careful planning is actually essential and important if you want a meeting to be successful and efficient and effective. So first is to determine the appropriate participants, then assess patient family needs, goals, values, and then we'll talk about meeting logistics. So for patients, certainly we want to involve patients in the family meeting process, especially that they're going to be the ones to make decisions for themselves. We also want to make sure that they are able to participate. So if they're having a lot of pain, having a lot of discomfort, maybe that may not be like the best time for them to engage in that process. With some patients and in some like cultures, they also like to defer to their family members, and that is also okay. It's also important and good practice to ask patients who they want to be part of the family meeting because there might be individuals or family members or friends that they don't want to be involved just because of conflict, tension, or unique family dynamics, and we want to be mindful of that. In situations when patients are not able to speak for themselves, it's helpful to review their advance directives to see who they have as their healthcare proxy. If you haven't heard about advance directives, it's a legal document for anyone who's 18 years of age and over. It's a document that allows individuals to appoint someone to speak for themselves in case they are not able to. And it also allows them to indicate and be specific about their healthcare wishes and share those wishes with their family members and the medical team. Sometimes we also have situations when it's still unclear who really is the healthcare proxy in the absence of legal documents or advance directive documents. In situations like that, here in the United States, we typically default to the next of kin, but we wanna bring that to like a different level in that, we want to consider individuals who actually have the patient's best interest. Sometimes it doesn't always follow or necessary that it has to be like a family member. We've had patients here at City of Hope who actually have designated their friends to be their healthcare proxy because they know that their friends would be able to make sure that their wishes and healthcare preferences are followed. With regards to the clinical staff, obviously we want to bring in those with expertise to influence decisions. These can include the primary care provider, the ICU physician if the patient is in the ICU. We also want to involve our palliative physician or clinicians because this is their expertise and they're particularly good in having these difficult goals of care conversations. If there are other specialists who are part of the treatment team, it's also worth considering involving them. And of course, the bedside nurse, just because they spend a lot of time with the patient and they have a lot of valuable information to share with the team with regards to the patient's clinical status. With regards to supportive care staff, we want to involve clinical social workers. And here at City of Hope, clinical social workers have a very strong and active role in facilitating and leading these goals of care meetings. There's also the chaplain who can provide spiritual support, especially for patients or families who may have some spiritual existential crisis. And I also mentioned about the child life specialist earlier. So in assessing patients and family values and goals, here are some helpful questions to ask them. And these are actually the questions that I often ask our patients here. What is most important to them if their medical condition gets worse? For some patients, it's important for them to be able to continue for as long as they can, regardless of their medical condition, or even if they're suffering. For others, they would want to do a trial of treatment, but stop if there is no meaningful recovery. Also, what are some abilities that the patient can't live without? Some may want to be, it's important for them to be able to be cognizant and to be aware of their surroundings. For others, it's important for them to be able to communicate and to have like meaningful conversations. This actually reminds me of a case I had a few weeks ago. It was a 72-year-old male patient who underwent a stem cell transplant, but was complicated with respiratory failure and brain failure. We had multiple family meetings, goals of care meetings to discuss with the family about the next steps and plan, considering his poor prognosis. The good thing about the case was that the patient was able to share with his family the things that matter to him, the things that are important to him. And that included importance of quality of life and being able to communicate, being able to have meaningful interactions with family members and friends. There's also the tool that I highly recommend to healthcare professionals, and that's the Serious Illness Conversation Guide. That's actually a tool that was developed by Ariadne Labs. I've used that as well in exploring more about patient values and what's important to them. And here are also additional questions to ask. What does quality of life look like to them? One of the questions that I also find meaningful in asking patients is exploring what their life was about prior to their illness. I think we can all agree that a cancer diagnosis or a life-threatening diagnosis can be very impactful and life-changing. You know, it can change relationships, it can change jobs, and for some patients, there could be a loss of sense of control and even with their identity. So with this question, it gives me a glimpse of who they are prior to their disease, and it also helps instill in them that even though they have the disease, they're more than their disease, and their disease does not define them as individuals. So with regards to meeting logistics, we want to ensure that there's adequate time, typically no more than an hour. Longer than that, and we run the risk of exhausting the patient, the family members, or even the medical team. However, shorter, if it's too short, we may not have adequate time to also be able to address patient concerns and then give them an opportunity to process some of the information that was shared. Next is the location. We want to make sure that there's adequate space for participants. This definitely has changed a lot with COVID or with the pandemic. Here at City of Hope, we have relied heavily on Zoom meetings, video conferences, telephone conferences in lieu of face-to-face conversations, just because of the restrictions and the limitations brought about by COVID. And again, that also adds an additional layer to the difficulty and the challenges that we encounter, with these situations, because a lot of patients and family members, they rely on the comfort, the presence of their family members, and with the limitations of COVID and our family members not being able to come and visit the hospital, that makes it even extra difficult for patients to cope with their disease and much more their hospitalization. So finally, we want to talk about the structure. This is the format that we typically follow at City of Hope. In our current practice, we have the pre-meeting, we have the meeting initiation, we have the clinical information, we have the reconciliation, the post-meeting. So for the pre-meeting, this is really an important piece or part of the process and should occur before a goals of care meeting can happen for many reasons. But more importantly, if there are multiple family providers or physicians that are involved with differences in opinions or differences in their medical recommendations, we want to make sure that before we meet with the patient and family, that there's alignment of care so that we can give them a unified message. It would be very confusing and even distressing for patients to get conflicting messages from different members of the team. So we want to try to avoid that as much as possible. For the meeting initiation, this is essentially this part of the meeting. It would be helpful to assign a facilitator. Again, here at City of Hope, clinical social workers play an important role in leading family meetings. So we're usually the ones to facilitate these goals of care conversations. Now, if you don't have a clinical social worker, you can also utilize other members of the team. Physicians can also lead themselves and nurses. And during the meeting initiation, it's also helpful to make sure that introductions are made. We want to make sure that we know who's in the meeting and we know what the roles are. And with the family members, it's also important to know what their relationship is to the patient. For the clinical information, this is really the sharing of information about the patient's disease, the patient's clinical status, the patient's prognosis and treatment options. And I want to talk a little bit about prognosis because that is often a challenge for us to share that information. And I think for many reasons, there's discomfort, and unintentionally there could be also overestimation of prognosis. However, that's a crucial piece of information to share with patients so that they can have an accurate understanding of where they're at with their disease. That way they can make the best decisions for their care. Patients and family members often make decisions based on the knowledge and the information they have about their disease and prognosis. And if they don't have accurate information about their prognosis, there's the risk that they may not also be making the best decisions about their care. For the reconciliation, once clinical information is shared with the patient and family, we also want to make sure that we're able to reconcile the medical recommendations with the patient's values. And that's just to ensure goal concordant care. This is also an opportunity to address questions and concerns, and also more importantly, to provide emotional support, spiritual support. As I've mentioned earlier, it could be difficult for some patients and family members to have these kinds of discussions, especially if it's a heavy one. So we also have a responsibility to not only address the medical needs of the patients, but also to make sure that we provide them with the support that they need so that we can make this process as easy for them as possible. And that's also one way that we create and reinforce and strengthen our trust and relationship with that.
We have about
and lastly,
7 minutes.
For the post meeting, it's not a requirement, but it's also helpful to debrief as a team, to reflect on the case, especially if it was a really difficult one. It's helpful to think about what worked well in the meeting, what were areas of growth opportunities, or how could we have done things differently in the future. Especially with difficult or complicated cases, that is also a good time and a good space to support one another as a team. So I just want to share this briefly. This is a diagram that captures all the information that we've talked about with regards to meeting preparation. This was actually in the book chapter that Dr. Mooney and myself wrote for the psycho-oncology textbook. And lastly, I want to share and reinforce that goals of care family meetings are not a one-time event. It is really a process. It is ongoing discussions because decisions change as the patient's medical situation changes as well. And especially when it comes to decisions about life-sustaining treatments or stopping life-sustaining treatments, often these decisions just don't happen overnight, but is typically a result of a very intentional process. I also want to mention and acknowledge the reality that sometimes even with the best of intentions and the best patient and family goals of care meeting practices, there are still times when it's really difficult to come to a mutually agreed upon decisions between patients and the medical team. And that can sometimes result in frustration on all parties involved, the medical team, the patients, and the families. It's also during situations like this that is even more so important that we are able to maintain communication, maintain compassion, and maintain connection with our patients and families, because ultimately our goal is to make sure that we provide patient-centered care and excellent care for them. That's my information, my contact information, in case you have additional questions.
Dr. Miller, you are currently still on mute.
Okay. Hi, this is Dr. Marinel said it's Ken Miller. First, I want to thank you. That was a wonderful talk and an incredible summary of a really important topic. So, but I'd like to I want to pose some questions, a few from me, but first a couple from participants as well. We had a question from a colleague in Mauritius. And their email basically says, I'm going to try to paraphrase, that often there's a disconnect between what the clinicians may perceive as the reality, the prognosis, and what the family may perceive as, and the patient may perceive. In fact, there may be three different perceptions. How do we avoid that?
Mm-hmm. Thank you, Dr. Miller. That's a really great question and an important one, because we often run into situations like that here at City of Hope. This is why communication is really important. It's important to understand where patients are coming from. I think it's important that we have situations like this that we just don't put our own agenda at the expense of values and things that matter to our patients and their family members. I think the key is to make sure that we have ongoing discussions. This is not a one-time thing. This is often a series of conversations so that we can make sure that we fully understand each other. And sometimes it takes multiple tries to be able to be completely aligned together and to be on the same page.
We had another question from Kenya. I found this one really interesting. What is the distinction between hope and false hope?
Okay. What is the distinction between hope and false hope? Honestly, I haven't really thought much about the question. Hope is something that one aspires to have, right? And we don't want to take that away from our patients and families. And I do believe that nobody can really take away hope from anyone. False hope at the same time is giving information that we know is incorrect. And it could be coming from different intent or intentions. It could be because we're afraid to hurt their feelings. We're afraid about the discomfort and the emotional distress that could arise if we provide accurate information. So that, I would say, would be the distinction between hope and false hope. False hope is giving inaccurate information when we know that that's not the right information to share with patients and family members.
Good. Thank you. These are, I think for all of us, these are challenging and difficult conversations. So I really want, we had a question from a colleague in the Congo, and I'm going to ask it for me as well. How do we start the conversation? And it may not be a formal goals of care conversation, but in your practice and what you've seen at City of Hope, very practically, what are some words to use to start these conversations about life and about death and about prognosis and about goals of care?
Mm-hmm. Clearly, this is not the easiest of conversations, and it can be a delicate one. And if, in fact, even in some cultures, it could be a taboo because nobody really wants to talk about end of life or our own mortality, right? I think we can begin from where the patient or the families are coming from. Get to know them. Get to know the patient as a person. What are the things that are important to them? What are their values? What are the things that bring them joy or the things that they're able to find meaning in the midst of their illness? I think once we are able to get to know our patients in a more personal level and we're able to build that trust and relationship, then it's also a little bit easier to like progress and have the more difficult conversations. I could just imagine like meeting a patient for the first time and just start talking about, goals of care and death, because that could be very overwhelming and that could also impact the relationship, the trusting relationship. So we want to make sure that we dose that information. We want to make sure that we present information in a way that it's also easier for them to digest and to process and given in doses. But I think overall, I want to leave with a message that, trust and relationship, I think, are the foundation of these goals of care conversations. Without trust and that strong foundation of relationship, it's going to be very difficult to bring these conversations and get the family members to be on the same page, especially when we're hoping for them to make critical and difficult decisions about their loved ones.
Yeah, and I've finally one last one. Let me find it on my papers here. City of Hope, I know to be in Los Angeles and that whole environment's very multicultural. So again, how do you, and you have a lot of experience with working in a multicultural milieu, but for people that don't, for clinicians who don't, again, how do you explore? What are some ways to actually ask very practically about what works for people with different backgrounds?
Dr. Miller, I'm sorry. I just want to rephrase the question, make sure I understand it correctly. So are you asking about like practical tips or recommendations for patients who are coming from different backgrounds, or for clinicians?
I think for clinicians, how do we as clinicians, if we're not familiar with the Chinese culture and how they deal with goals of care and end of life issues, or a Bolivian culture, for example, how do you ask about that and learn?
Really, really important and great question as well, because, especially here in Los Angeles, we are a very diverse community, and cultural factors do play into role, especially with some of these, situations. So I think I would start with having cultural humility. And when I mention about having cultural humility, it's being curious about the culture, like the traditions, the things that are important in a specific culture. I think when we have a better understanding of what works for them, what could be potential barriers, things that are important for them to observe as traditions, then we can help align ourselves and introduce things that make sense and are appropriate in their culture.
Anyway, well, firstly, let me thank you. It was a wonderful talk and really interesting information and very, very relevant. So
thank you.
Marinel Olivares, thank you.
And Dr. Miller, I also want to add, I feel like I didn't explain myself very well, but the cultural humility, I think here at City of Hope, we have ongoing efforts to educate our clinicians, to provide education about cultural competency, so that we can be culturally sensitive when we're dealing with patients with cultural issues that we need to be mindful of, and we need to make sure we consider and think about when we're doing our interventions and conversations with them.
Good. Thank you again.